So good afternoon, everybody. Firstly, I'd like to wish you a warm welcome to today's webinar. Thank you all for joining us for the official launch of the Revolution Vibe. My name's Lee Blanchflower, and I'm the CT Modality Manager for GE Healthcare across the UK and Ireland. Now, before we get underway, there's just a quick few housekeeping points. Firstly, as you join the webinar, you may have noticed that your permission was requested to record the session today. So yeah, thank you for accepting. This just means that we can share the information afterwards over the coming weeks. Secondly, we're also going to be holding a short Q&A in any remaining time that we've got at the end of the webinar. So to give speakers a full opportunity to present, please could I ask for any questions to be posted in the Q&A section as we go along. You should see the Q&A sign just in the top ribbon of Microsoft Teams. Now, if you do see a question which you'd like to see prioritised, please make sure you vote for it, and we'll ensure to focus on those first. Now, what we'll be doing, any questions that we don't have time to answer at the end, we'll be trying to collate them, and we'll be following up over the coming weeks with a recording of the webinar. Now, today marks a very exciting day for us at GE Healthcare. With the launch of Revolution Vibe, we believe that we're going to be delivering a new vision for every heart, which is going to help patients across the country access the latest innovations in cardiac CT, which will enable earlier and potentially asymptomatic detection of cardiovascular disease, all whilst creating a clinical and operational efficiency across the imaging department. Now, we're delighted to be joined by a fantastic group of speakers today. Shortly, I'm going to be handing over to Rafael Sanchez Montero, International Product Manager for Premium CT segment here at GE Healthcare. And Rafa's going to be introducing the Revolution Vibe in more detail. Rafa will then be passing over to Dr. Stephanie Bischnau from Radiomed Hospital in Wiesbaden, Germany. And Dr. Bischnau will be sharing their experience of piloting the Revolution Vibe throughout last year. And then finally, we're going to hear from Dr. Sri Iyengar, who will share how the advances seen on the Revolution Vibe and the technology associated have helped drive clinical and operational efficiencies in cardiac CT at Frimley Health NHS Foundation Trust. So thank you again for being here. And with that, I'll hand over to Rafa to get us started.
Thank you very much, Lee. Oh, sorry, I'm not sharing the right one. Sorry about that. Let me share this one here. Okay, let me know when you can see my screen. Is it okay? Good?
We can see we're good.
Yeah. Okay. So thank you very much. Today I'm going to be going through the main reasoning why we wanted to develop a system such as Revolution Vibe and what was motivating us to try and get this new vision for every heart that we think we're bringing with Revolution Vibe. And in order to do that, I'm going to start by acknowledging the clinical community. You know, you are all experts. You all know that cardiac CT has become a frontline non-invasive imaging tool for diagnosing and therapy planning and monitoring of cardiovascular disease. And this, all of us that have been working in the CT industry for the last 20 to 25 years remember back in the day when we saw, kind of a bunch of pioneers trying to imagine a future where cardiovascular disease could be diagnosed, effortlessly in a CT lab, and that has been made possible only thanks to the combined efforts of course, the clinical community that has embraced this and all the challenges with the early technology and all the shortcomings. Of course, the researchers that have proven that this technology has an important role and an impact in the patient outcome, and of course, the industry that has been taking all these feedback and getting better. And but as cardiac CT use is growing, as we open, so do the challenges, right? We need to be able to achieve consistent image quality for even the most challenging patients. I mean, in the early days, we were able to kind of cherry pick the patients that we wanted to have this kind of more, so to say, not so proven technology. Now it's no longer the case. We need to take every patient. Then the second thing is how can we manage the rising demand as the test is proving its point. We're gonna have to be facing exponential growth, as this has been proven by many societies. And third, how can we enhance cardiac CT and manage rising costs? Because as the guidelines are publishing in the different societies, this one here is referring to the one published by the European Society of Cardiovascular Imaging. Technology is still a gatekeeper. Yes, cardiac CT is a first-line test and it's appropriate first-line test for the use for the evaluation of patients under different conditions, but still depending on the technology that you have available in your department, CCTA could not be recommended in situations that may hamper image quality, like extensive coronary calcification, irregular heart rate, significant obesity, inability to cooperate with breath hold commands, et cetera, et cetera. So this means that technologies that keep a gatekeeper and that very advanced scanners are needed to manage the most complex patients and also improve workflow and cope with increased demand. And talking to the UK community, you came early into this game. Upon the approval of the NICE guidelines back following the Scott Hart trial, okay, the British Society of Cardiac Imaging already issued a paper to understand what were the challenges that we were facing if we were going with cardiac CT as a first-line test. And of course, the first one is we need to have appropriate cardiac-enabled CT scanners with adequate reporting workstations, and then the workforce, radiographers, nurses, radiologists are required to be appropriately trained to acquire images in all patients, including those who may be technically challenging, high heart rates, arrhythmias, high BMIs, etc. Right? And there has been a lot of work being done, excellent work being done in the UK around this to become more efficient, to understand how can we provide excellence of care while expanding the access to cardiac imaging. And I'm just going to highlight the work that one of our partners has published, the University Hospital of Plymouth, the NHS Trust in Plymouth. They actually took on this challenge, and they were able to prove that it was possible to do drugless and radiographer-led cardiac CT, provided you have the right technology in place, the right training for your radiographers, and the right setup. And they were able to achieve all of this with a 96.5% diagnostic scan rate. With all of this, even with patients who were 10% of patients with heart rate above 90 BPM, and out of these 10%, 4.5% had more than 90 BPM and irregular rhythm. So this is proving the point that with the right technology, you can approach this. And of course, the final outcomes is increasing access and being able to basically increase your scanning throughput with the goal of having mostly reducing their CCTA waiting time from 120 days, that was an average when they first, before they implemented this, to less than 30 days, and many other advantages. But what is the caveat here? That advanced CT technology is the enabler. And in our vision from GE Healthcare, Unlimited One Big Cardiac is a key enabler to be able to have this kind of approach in which we are democratizing the access and we are expanding the use of advanced cardiac imaging to more patients. And among the key enablers in our technology for us to be able to claim a limited one big cardiac is obviously to have full organ effective coverage. We do believe that in order to be able to manage the most complicated patients, scanning always in a single beat through wide coverage is important. Second, of course, we pair these with an image chain that includes the necessary power and the temporal resolution and the rotation speed to be able to manage the most complicated patients. And one of them that is usually very overseen is what do you do in order to be able to tackle any residual motion, and the access to the second generation motion correction is another key enabler for our unlimited one big cardiac. And I'd like to stop for a second on the second generation motion correction. We have been investing heavily in this since we introduced our first Revolution CT. We are already in the second iteration. This iteration is able not only to correct for the coronary artery movement, but as you can also check over here, it's also able to correct for the movement in any of the cardiac structure, providing more crisp valve evaluation, coronary, papillary muscles, valves, and all the cardiac structures within the volume are corrected. And we do have a really excellent track record and excellent experiences of improving how not only coronaries, but also structural heart disease, which is another growing area of demand for cardiac imaging. We can really provide a very, very good solution. And you don't have only to trust what I say. We do have a wealth of clinical peer-reviewed evidence that we have compiled, and we will be happily sharing with anybody that requests for it. So all of this gives us a possibility to have excellent image quality for the most complicated patients. Improved spatial resolution is also another thing that we have invested and we are now implementing in our Apex family. And but not only the perfect image quality patients need to be scanned. We also need to be able to tackle those patients where back in the day, we could not achieve it. I mean, patients with atrial fibrillations, patients with high heart rate, patients with arrhythmia. And this, again, we do have a wealth of publications with cohorts. This is a publication from the team at Cardiologico Monsino, 100 patients with high heart rate above 80 BPM, showing similar image quality and diagnostic accuracy in the group of the control heart rate versus the high heart rate. And the same type of approach was repeated for patients with atrial fibrillation, where we were able to have similar image quality and diagnostic accuracy for patients with atrial fibrillation at a very, very, very reasonable dose. And again, we do have a wealth of clinical peer-reviewed evidence. The team will be happy to share with the participants who request access to it. So the big question right now that we need to answer, if we look at how can we achieve consistent image quality, how can we manage the rising demand, this is something that through high-end technology, we are able to tackle. So the third pillar is, okay, how can we make these excellent cardiac CT technology available and manage accessibility while managing the rising costs? Because it's no longer enough to have these very high-end scanners in the level 3 hospitals. We want the CDCs, we want the private practices to really get access to this type of technology. And our solution is the Revolution Vibe. So what is the Revolution Vibe? The Revolution Vibe is a system that we have built on the legacy of our Revolution Apex platform, delivering unlimited 1-beat cardiac, designed to provide consistent, high-quality imaging for every patient, right? Even in challenging conditions, breath-holding tests, and it's a spectral system for general imaging. Second, effortless cardiac workflow for every user with an AI-powered workflow that streams the scanning process. And third, and most importantly, we have very, very intelligently designed this scanner with a lower lower product lifecycle costs, featuring predictive maintenance, cost-saving contrast media management, energy-efficient features, to be sure that we can put this type of technology in the hands of more professionals to serve more patients. Again, as I said, it's built on the legacy of the GE Healthcare premium cardiac scanners, shares exactly the same components with our Apex platform, and expands access with leading-edge cardiac technology. We do have a pilot site that we have the pleasure today of having the team of having Dr. Stephanie Bishnau from Radiomed in Wiesbaden, and I'm going to hand it over to her for her to share her clinical experience and operational experience using the Revolution Vibe in the pilot site.
Yes, hello from Wiesbaden. Can you hear me?
Yes.
Okay, perfect. And now I hope you can see my presentation. There it should be. And I'd like to share our new vision for every heart from Wiesbaden. Well, I'm going to talk about quickly who we are and what the market trends in Germany are in the moment, and then I'll share our GE Revolution Vibe pilot project with you and give you our experience concerning those image quality success rates with the new system in opposite to the old one. And I'll give you a peek into our first weeks of operation, and I'll share some clinical images and last our conclusions. Well, we are a private practice in Germany, in Wiesbaden, for radiology and nuclear medicine, and we are 11 partners and have over 300 employees on 9 sites in Wiesbaden and in the Rhine-Main area. And this is our CT team, and we are doing cardiac imaging for a long time, starting 15 years ago, and we're doing cardiac CT, cardiac MRI, and myocardial scintigraphy. Well, the market trends are quite difficult in Germany in the moment. We have cost increases everywhere. And we also had a decline in public fee schedule in radiology in 2020. And we also have an effective decline in private insurance because we didn't have any adaptation since 1996. And the coronary CTA was newly introduced in Germany only in January 25 for public insurance. Before, we could do cardiac CT only in private insurance, but the reimbursement was much lower than we expected. We only get 159 euros per cardiac CT, and that was really a big disappointment. So I guess every radiologist in Germany thought about not doing cardiac CT and public insurance. But then we thought that we radiologists have been assigned to play a decisive role in diagnosis and management of chronic arterial disease. And we are willing to accept that challenge. But it's difficult because we have a very high demand in general imaging, and the demand on CCTA goes on top, especially in this year, which is the first year where we do it for the public insurance. And the reimbursement is really difficult, and it's really it's very challenging to invest and make investment decisions for the future. Well, we had a quite good experience with the old system. We had a good dose performance and a good image quality, but that was always at the cost of a very high level of supervision by us radiologists. And we had a thorough patient preparation, and the slots for cardiac CT lasted 20 minutes, whereas the rest of all the examinations were 10 minutes. So we had some tough goals with the renewal of the new system to be able to offer CCTA in public health insurance. So we wanted to have an increased operational efficiency. We didn't want to have a radiologist workflow anymore. And of course, we wanted to have a low training requirement for our staff. then for sure we wanted to have lower radiation and contrast doses as before and an improved patient experience. And we also need an increased technical success rate for cardiac CT, and we also need the around capabilities. So what convinced us of the new VIBE system was the coverage of 160 millimeters detector, which allows us to do 1-beat cardiac imaging with a very high rotation time of 0.23 seconds and a very high tube performance and a robust motion correction, possibility of deep learning, image reconstruction, dual energy spectral imaging, and very important for us as well, the workflow automation. Well, we finally installed the system in September 24 last year as a pre-series pilot project, and that was the first system installed for the global market. And we gathered feedback for the final release product. We did a re-evaluation of our entire clinical workflow, and this includes reviewing all walkways, all patient path, workflow steps, room equipment and positioning, and the staffing concepts. And we did some construction work to accommodate a third dressing room as a preparation room for pre-medication, placing IV lines and ECG electrodes to increase the patient throughput in the scanner room. And this is some plans from our construction phase. You can see the new scanner room in here. And we have now 3 preparation cabins. This is the preparation cabin in the middle where we put all the needles and everything. So we have a very short stay in our scanner room and no loss of time, for example, with difficult IV lines and things like that. Well, we started after a minimal staff training off-site, and our team was quickly very confident to perform the first cardiac exams right away. And the application took place nearly parallel to full operations because we had a really high demand after our construction work. And we did a fundamental change in our approach to cardiac workflow. We didn't apply nearly no beta blockers anymore. We had no radiologist supervision anymore, but just let the tech-only workflow go. And we just relied on the fully automated protocol selection on scanner side. Well, we then did a comparison between the new and the old system and did some qualitative evaluation concerning dose levels, image quality, and artifact frequency and success rates. And we did that on the based on the last 100 patients we had on the HD system and the first 106 patients we had on the new VIBE system. And what we found out is there was not much different in patient demographics concerning age and body mass index. What we saw is that we had a slightly higher heart rate on VIBE than on HD. And one reason for that is that we had a minimized use of beta blockage. And we also recruited more arrhythmic patients, as you can see, and more variable patients as before. What happened to the radiation dose? Well, the radiation dose was already quite good on the old system with 8.5 milligray, but on the VIBE you can see is even slightly higher CTDA with 8.9 milligray. And same if you have a look at the DLP. But one reason for that is the median coverage. So on HD, we radiologists were always present at examination, and we fighted for only 3 4-centimeter blocks to avoid stepping artifacts. So we had a median coverage of 120 millimeters. And on the new system, we didn't have a radiologist supervision, so the technicians decided often for a coverage of 160 millimeters to avoid to miss some anatomy. But what we saw was a dramatic change in arrhythmic patients. Before, we had a CTDA of nearly 36 in arrhythmic patients, and with a new VIBE, we had a CTDA of only 19, and it's even more obvious if you compare the DLP, which was 570 before and is now only 210, which is really amazing. Well, what happened to the image quality then? The image quality was better for all patients, no matter whether they were stable, variable, or arrhythmic. And we scaled the image quality in a 3-point scale with good, adequate, and suboptimal. And what we saw on the all system, we had a suboptimal image quality in 23% of all patients, and there was a success rate below 80%. But on the new system, we had a suboptimal image quality in only 4%, which is a success rate of 96%. And the main reason for that was that we didn't have any stepping artifacts anymore. We could reduce our contrast usage from median 100 millimeters to now 63 millimeters. Well, but that's been just theoretical stuff, and I'd like to share some clinical images. And that's what we all love. It's a rule out of coronary artery disease, very quick, very easy. And this was a patient with a heart rate between 65 and 78 beats per minute. And we didn't apply any beta blockers, and we got perfect pictures with a dose of only 0.5 millisievert. And the system decided for more diastolic imaging, so automated workflow. This is a more complicated patient with arrhythmia, heartbeat between 82 and 130, and the system decided for more systolic imaging. And as you can see, you have perfect pictures without any motion artifacts, and where the post-processing with snapshot free, as Rafa already told you, it really brings us perfect pictures. And this is a patient, 80 years old, with a strong plaque burden and a calcium score over 3,000. And we can assess coronary arteries very well, see some critical stenosis in LID, and the dose was only 0.7 millisievert. And just to give you some more impression, this is a patient with a lot of calcified and soft plaques. And another one, you really have a high clarity for plaques using SF-free for motion correction and processing with true fidelity. This is a 65 years old patient who came for stent evaluation, and we could confirm stent patency with a quick rotation time of 0.23 seconds. And this is a patient with an anomalous RCA origin. And this patient presented with heart murmur, and again, we didn't apply any beta blockers, and we saw big coronary fistulas in LID. And of course, we're doing a lot of bypass evaluation, and in this case, we used two 16-centimeter blocks. And we're also doing a lot of aortic imaging, and this is a patient who came for post-operative stent evaluation, and this is an ungated helical scan. And you see that we don't have any motion artifacts. And of course, we're also doing TAVR staging, and this patient came for TAVR staging and assessment of an aortic stent. And you can also see the coronary arteries very well. No motion artifacts and a very low dose again. And in this case, we used 2 blocks of axial gated scan followed by an ungated helical scan over the abdominal and pelvic arteries. And of course, we're not only doing cardiac imaging, but we also have a huge range of application because the system is our daily workhorse. So summing up, for cardiac imaging, we don't see any stepping artifacts anymore. We have a very high cardiac motion robustness and a very high success rate for cardiac CTA. And in general imaging, we also have a great versatility beyond cardiac with excellent image quality and a high dose efficiency. And for patient impact, the new system is very important. So we see a dose reduction on a arrhythmic patient of 47%, which is really amazing. And we have a reduction of contrast media of 37% and a minimized use of beta blockage. And it also had a great impact on success and quality rates. So we see a success rate of 96% for all patient times and don't see stepping artifacts anymore. And we recruited all patients where we had always some dropouts with the old system because of arrhythmia or high BMI or because the patient couldn't hold breath long enough. So we don't see that anymore. And we have a better image quality, especially in variable and arrhythmic cases. Well, what we saw that we have a much lower radiation dose in arrhythmic patients because we don't use the helical retrospective mode anymore, but only have one beat prospective cardiac CT. But we didn't see a dose reduction for general cardiac imaging in the pilot phase, but you have to take into account that we had a very high level of supervision on the old system and no level of radiologist supervision on the new VIBE, and we didn't nearly give any beta blockage anymore. So we still see some potential for further improvement by limiting the set axis and by doing a pragmatic heart control and minimize our exposure window. And we can also learn some things from pilot phase and do some scan optimization. Well, as you can see, the new system had really a great impact on our workflow. We had a really short operator training, and the new in-room workflow automation and the scan protocol assistance leads to a no radiologist workflow anymore on cardiac imaging. So we radiologists are not needed any longer. While we saw a great impact on our productivity and had 50% of time savings on coronary artery, on CCTAs, because we could reduce our time slots from 20 minutes to 10 minutes. We also saw an increased general performance, and we radiologists had 5 minutes of freed up time for at least for each scan, and that gives us time for case interpretation. So as you can see, we're really very content with the new Revolution VIBE. It showed a great performance during pilot phase, and it has a high operational efficiency without any decrease of image quality and technical success rates. And the automation in different areas led to an improved tech workflow and dramatically reduced our necessity of involvement of us radiologists. And we have freed up resources that enable us to deal with the increased demand. And we also get great feedback from our patients and from the referring physicians. And we think that optimization has not yet reached its full potential, and we still are continuing to improve. That was it from Wiesbaden, and I'll hand over to Sri.
So you can see the correct screen, I suppose.
We can, yes. Thank you.
Excellent. So, I'm just going to kick off this presentation. So I'm Sri Iyengar. I'm a radiologist. I work for Frimley Health NHS Trust, and I work for Wexham Park and Heatherwood Hospitals. So I'm just going to share my experience of the Apex upgrade to our Revolution system and sort of demonstrate what sort of efficiencies we've managed to acquire. So Frimley Health NHS Trust is a large-sized DGH. We're in the south of England. We've got 3 main sites, 2 acute sites, Wexham Park and Frimley Park, and an elective site at Heatherwood Hospital. We serve an approximate population of about 1.1 million, which is of mixed ethnicity. So we've got quite a varied sort of population of different backgrounds. For us in radiology, we are two main departments with almost 140 staff, about 42 radiology consultants. We have 8 CT scanners, a mixture of GE and Canon scanners, few MRs, and the rest that a general radiology department has. Our cardiac imaging is done on 3 sites. So we have an elective site, which is Heatherwood, which is shared across both the acute sites, and inpatient CT offered at both the acute sites. For the Heatherwood site, we have we used to have a GE Revolution CT, which then we upgraded in May last year to an Apex. Our cardiac imaging includes the general mix of cardiac CT, cabbage scans, TAVIs, post-surgical valve assessment, left atrial assessment, and hypertension. So it's a general all-round mix of cardiac imaging. So the reason we went for an Apex upgrade is because we had a sort of a roadmap in mind. Firstly, our requirement was increasing year on year, and we needed increased capacity across all our sites. The second bit obviously was that we had no scanner time available, so we really didn't have any extra resources, no extra scanners to be bought, no extra scanning time, and we had to squeeze in the extra capacity within the time we had. We also wanted to improve our image quality for some of the more difficult to image patients. Now, despite it being a single heartbeat scanner, we still had a few limitations to our Revolution CT, purely because of mixed amount of supervision to get scans. Higher level of radiologist supervision would lead to a better quality imaging data set. Lower levels would lead to slightly deterioration of image data, and hence we wanted to improve it up to about 95%, where it was much better diagnostic confidence. We also wanted to try and trial the radiographer-led list system where radiologists weren't involved in supervising, or at least minimal supervision. But we took a slightly different tack on that, saying we would like to actually reduce our beta blocker administration, which means we're not going to end up training all our radiographers to administer beta blockers to a large volume. We also wanted to reduce the number of times they were changing the protocols to fit the patient's ECG or their heart rates. And we want to try and offer in the future cardiac CT imaging in the primary care setting, which would be our ultimate goal. So the Apex upgrade, we upgraded from the Revolution CT to Apex in May 2024. The way it went was our scanner had a downtime of 2 weeks. We had installation for the first week and then physics testing for the second week, along with initial training of the radiographer. So it was a very short turnaround time. The upgrade gave us a faster rotation time of 0.23 seconds and higher tube capacity. Everything else was pretty much the same because we are used to using the Revolution platform for the last 7 or 8 years. In terms of radiographer training, we had 2 radiographers per list for the first few weeks. We had a senior radiographer and a trainee. All our radiographers are cannulation trained. All of them are ILS trained. We developed a PGD, or patient group directive, for administration of sublingual GTN, and all our scans were supervised. This is how we used to run our Revolution CT service. We continued to do that for the first couple of weeks with the new Apex upgrade, which then included CT-specific training on dedicated list for a month, with the radiologists and the apps team training the radiographers up. We also introduced some ultrasound-guided cannulation for the radiographers. We added a PGD for IV beta blockage to be given by the radiographers themselves. And we introduced the concept and started trialing minimal supervision so that the radiographers didn't really need us around to try and supervise the scans. Just to show you how our workload was, we are a busy unit. We do approximately 3,000 cardiac CTs a year. And we've noticed that there is a between 10 and 12% increment in cardiac CTs every year across both sites. We really don't have any spare capacity for expansion. So if you look at the year before, when we were running our Revolution CT scanners, we did 3,200 scans over the year approximately, of which 2,700 were done at Heatherwood on a single scanner. We used to run them at 30-minute slots with about 2,100 scheduled slots, and then always catch up over the weekends with extra lists and paying people extra and doing waiting list initiatives, as we call it, to try and match up our demand to try and keep the waiting list to a manageable extent. What we then moved over to in the business plan was when we had the Apex upgrade, we would change the 30-minute slots to a 20-minute slot, which would then increase our capacity to 2,700 scans within the same time period that the scanner was available. And that would allow us to stop any of those weekend lists, because you can see the difference is the catch up of 600 scans. And then that would also allow us to run our scanners faster and more efficiently. So the workflow changes that we administered were that we changed our CT slots to 20 minutes. We still have late additions and walk-ins from the rapid access chest pain clinic. This is just for us to keep the same day cardiac service running as an adjunct to what we do in primary care. We changed the CT acquisition roadmap. We also changed the way people give beta blockers. We haven't introduced oral beta blockage, but we have reduced our beta blocker usage. We kept a tab on the radiation dose, and we also kept a tab on our image quality. The aim was for the radiographers to independently run service on the scanner with a future view to having a Revolution Vibe on our community center so that we could run independent lists and walk-ins for cardiac service. So this is the CT roadmap that the Revolution CT came with. As you can see, there is a very small area where we do a cardiac sort of axial acquisition at a very narrow window. The rest of them were with a bit of padding, and there was this constant pull and push between the radiographers to try and optimize the scan quality versus the heart rate. And it required a lot of supervision from the radiologist and quite a lot of beta blockage. We then moved to an Apex upgrade and Apex roadmap, which we then modified. And as you can see, almost across the board, through a large volume of patients and a large difference in heart rates, we acquire the scan at a very narrow peak. We just do 75%, and we really don't acquire anything else. So that's the bog standard and the workhorse acquisition protocol. I'm just going to show you a couple of cases. This was a standard typical case that we had on the list. A 52-year-old male, recurrent anginal chest pain, was already on bisoprolol. The reason I say that is because then IV beta blockage to a certain extent becomes ineffective. It's the heart rate that they come as the heart rate that you accept. Reasonably large BMI, baseline heart rate of 76. We still tried giving him 30 milligrams of IV metoprolol to see if it makes a difference. Standard contrast volumes, and that's the sort of scan you'd expect. And you can see the scan quality is extremely good. Even with the heart rate of 76 beats per minute, there was very little to no motion artifact at all. And we did use motion correction in this case to try and give us the image quality that we required. And I think the DLP is quite acceptable at 145. So that's the sort of image quality you can expect. Another case where 46-year-old female, atypical chest pain, extremely anxious, coming onto the table, was extremely worried because she had a good family history. We thought she had a bit of stable asthma, very mild, never been admitted to the hospital, reasonable BMI. Baseline heart rate was 98 beats per minute. We gave her 20 milligrams of IV metoprolol, which is what we would do through our radiographers via the PGD, and the heart rate dropped to 65. So we find a lot of patients in that cusp of between 60 to 70 beats per minute, where the old Revolution CT would have to pad these scans. We don't need to do that anymore. We can just acquire at 75 to 75%. So the radiation dose is within limits, but we don't worry too much about heart rates going up to 70. And the DLP was 121 here. And as you can see, that's the image quality we get. You might see in the first set of images, there's a bit of motion artifact in the right coronary artery. And then if we then go on to the other images with the motion correction, you can see that the motion artifact in the proximal right coronary artery has been almost completely eliminated. So very good image quality with acceptable radiation dose with very minimal supervision. So how do we express ourselves now? Our Revolution CT, the old scanner, we used to beta block between 60 to 70% patients. I looked at it over a long term, and we roughly beta blocked about 62% of our patients. Slightly lower than what we would like, but there is a variability in practice between radiologists, and hence there is that level of undersupervised or non-supervised scans with no beta blockage. With the Apex, we've actually looked at it, and our beta blocker usage has dropped to below around 20%, which is pretty good. So only 1 in 5 patients actually get beta blockers. Baseline heart rates we used to accept at about 60. We had a reasonable variability in the previous scanner. With the current one, because we are accepting higher heart rates, our average heart rates are about 69. We acquire the heart rates at about at 63, whereas previously we used to have a very tight heart rate control at about 55. In the scan acquisition, as you can see in the previous Revolution CT, a lot of the scans would have padding. So we would use 75%, but about no more than 60% of the cases, and then around 30% would have padding. Now, almost 76 to 77% cases are acquired without padding. So they're acquired at a narrow peak, and hence the radiation doses should be pretty good. And if you look at the KVs that we use, because of the higher tube output, most patients can be scanned at 100 kV. So that also helps the radiation dose. It also helps image quality. If you can look, the radiation doses are fairly equivalent. I'm not saying there's a big gain, but there is about a 5% dose reduction, which I think is acceptable because we're still learning our way around the scanner, and I'm sure there is a bit more to go with it. So we can reduce these doses even further as we tighten up our protocols and as radiographers get a bit more experience and we have much more tight selection of protocols. I'll show you a low dose case. So this is a 63-year-old female, reasonably perfect set of circumstances, keen athlete, very low BMI, baseline heart rate of 48, no beta blockers given, just a small volume of contrast of 36 milliliters, 80 kV scanning, and the DLP was 40. That's perfectly acceptable, very good quality images. I think we can go further down than this, and we can get scans at really, really low doses at very good quality. So looking at image quality, this is assessed by radiologists. As you can see, what you would want to expect is your images to be between scale of 5 and 4. That's the diagnostic range of images. Previously, what we used to get is about 65 to 70% images were diagnostic. Now we really go up above 75% at level 5. Another 32%. So you're looking at almost 92 to 93% patients with diagnostic image quality. Hopefully we'll hit our 95% at some point of time. The reason I'm saying that is because we're still adjusting the noise index on the scanner. We're still adjusting our protocols to get to the point where we don't have to supervise and we still expect standard, uniform, good quality images. This is a patient where the patient had come in previously on the Revolution CT scanner a couple of years ago with recurrent angina chest pain, and you can see the set of difference in image quality from the previous scan versus the current scan. So this is the previous scan. This was done on the Revolution CT. And you can see there is a certain amount of image noise. There is a bit of motion artifact. We did use the first generation of motion corrector to give us good quality imaging. What saved us was that the patient didn't have a significant amount of coronary artery calcification. And then if you look at these set of images, these are the images on the new Apex upgrade. It's the same scanner with the upgraded software and the upgraded tube and a faster rotation speed. And you can see there is virtually no motion artifact at all. And the image quality is vastly superior and at a very acceptable DLP of 93. We often get these patients. We get patients who are very high BMI. The highest we have now touched is 58. This is a patient with a BMI of 52, baseline heart rate of 67. We decided to give her a lot of IV metoprolol to try and drop the heart rate down so that we could optimize the scanner parameters. The DLP was needlessly, well, it was high. I can't sort of claim to be a low dose scan here. But if you see for a patient of such a large BMI, you will find that the image quality is perfectly acceptable. At the end of the day, it's important to get perfectly acceptable image quality. Otherwise, the radiation you're given to the patient is a waste anyway. So you're optimizing all factors here. So the things that you achieved with the Apex upgrade is that we've optimized our scanning protocols. We now have more radiographers running less and with minimal or almost no supervision. That would be in the roadmap to having completely independent radiographer-led lists. We've reduced our beta blocker usage, so I think that's important in terms of patient safety. It hasn't affected or actually improved our diagnostic image quality so that we can increase the envelope for all comers, and that would be trying to get us towards the path where patients can just walk in to have their cardiac CT without any barriers at all. So thanks to the radiology team at my hospital, because they work very hard and they put it all together and hopefully are helping our roadmap come to fruition. To all my colleagues and to the team at GHC who have helped us all through our upgrade and running of the scanner.
Shri, that's fantastic. Thank you so much. Firstly, I'd like to thank, obviously, Rafa, our speakers today, Dr. Bishnau and Dr. Iyengar, just for sharing their experience of how using technologies which are included on the Revolution Vibe, also things like the Apex edition upgrade, which Dr. Iyengar mentioned, using these technologies to revolutionize the cardiac CT service. Secondly, a huge thank you all for your patience whilst we resolved that slight technical glitch. Just to let you know, we will be distributing a full recording of the webinar early next week, so please do keep your eyes peeled for this. As we didn't have an opportunity to answer any of your questions, we'll also be providing this opportunities when you receive the recording. Then all the speakers on the call will be pooling together just to make sure that we're coming back to you with a response. Lastly, this isn't the only opportunity that you have to learn how medical teams like Dr. Bishnau and Dr. Iyengar are maximising technology to offer more efficient diagnostic imaging services to patients. We're pleased to confirm that we're going to be attending UK.io in Liverpool this year, and that's on the 2nd and the 4th of June, where we've got a fully loaded agenda of educational events on the stand. So please do pop along if you are attending. This leaves me to wish you all a great week, and we look forward to seeing you again soon. Thank you, everyone.